Hi, everybody. Thank you for attending this webinar, the lecture this evening. And the topic this evening is related to treatment of complex congenital deformities. It's quite a complex topic, so I don't have the expectation to clarify every single details on that, but just to give some kind of suggestion, and we may have the option to go deeper into this topic if someone of you will be interested in doing so. So all the philosophy, the rationale that we are using to make this kind of treatment comes from this guy, Gabriel Ilizarov. We have not time enough to enter the story of the relationship between Ilizarov and Italian surgeons, but just to say that Ilizarov was first hosted by the Italian Orthopedic Society on the human side, of course, in 1982, and with this kind of very specific technique for destruction osteogenesis. Just to give you an idea about how it was hosted and how his theory and practice was accepted at that time, most of the attendees at the Congress thought that they were not true cases. They just thought they were kind of cheating images. So just to say, that was the kind of approach, philosophical approach, that we didn't know at that time, and it was it had a major impact on the next approach to some very tricky and demanding clinical situations. So what is the basic rationale of Ilizarov technique? The fact that if we spread apart two pieces of vascularized bone, and please remember vascularized, okay? Because if we just take two dead pieces of bone, it won't happen anything. So we should start with two vascularized pieces of bone, and if we spread apart them, we won't get the vacuum inside in the middle, but we will get a kind of tissue. The kind of tissue that is called regenerate. Here you can see here, these are original pictures from Ilizarov. The reason why we have that high interest in his experimental work is because the experimental model for Ilizarov was the dog, and the dog for us, of course, is our patient in most cases. So we are specifically interested in knowing his work. You can see, and then in a second we will have further information about this kind of tissue. This tissue is regenerate. Regenerate means that the bone is able to form a matrix, bone matrix, and this bone matrix eventually will ossify, will calcify, and its features will be eventually the same biomechanical and biological features as the parental bone. And this means conceptually a major issue, that we are creating new bone. We are not adding bone, moving bone. We are creating bone. And this is something that is very peculiar. Okay, what happens? What happens during this? We are not entering the specific technique for every kind of calculation we need for the treatment of the patients that I'm going to show you, because this is not a course and we don't have time, but let's say general principles, okay? So also the technical details, we are starting with an osteotomy. And the osteotomy is completely accepted all over the world, that can be performed by an oscillating saw, provided that we flush in a very continuous way during performing of the osteotomy to avoid any kind of thermal necrosis of the bone during the cut. Okay, so we start with that, and then we will leave some days of latency. What is the latency for? The latency is for forming a gain of microvascularization in the area of osteotomy. We start with that, and then we will start proceeding with the spreading of the two bone fragments. How much should we spread? The general approach is 1 millimeter per day divided into 3 times, okay? And this can be easily achieved acting on the nuts of the frame. So again, I don't have the time to enter any single technical detail, but just keep in mind 1 millimeter of spreading, of lengthening, but divided at least in 3 times per day. What would be the optimal lengthening frequency rate? It would be continuous, okay? If you can perform it 4 times a day, even better. If you can perform it 6 times, of course, dividing the overall length, meaning dividing the millimeter per day into 3, 4, 5 times, okay? Why? Because in this way, we are stressing the least possible, in the least possible way, the microvasculature that we need for the new bone formation. What is happening in this phase a few days after starting of the procedure? That we have the formation of a fibrovascular tissue. You can see here the bone. This is the fibrovascular tissue, okay? And this fibrovascular tissue is not visible radiographically, of course, because there is no calcium inside yet. So we cannot see it, but the important thing is that this fibrovascular tissue is already with all the spindle cells that are oriented in the same direction as the force of destruction. So they are already oriented in the same direction of the destruction that we are going to apply to the bone. Okay. In a few days more, we start looking to this area, that is foggy area. You see here and here. Okay, this is this when the regenerate starts being visible radiographically, and this is due to the fact that we have calcium inside it. At this stage, we have collagen fibers bundle that extend between the spreading of the 2 fragments of bone. And again, these collagen bundles are oriented in the same direction of the force that we are applying to the bone. And if we proceed, we can check for the quality of the regenerate. This is very important because sometimes we have to accelerate the destruction rate. Sometimes we have to go slower, because if we don't reduce the rate, we will damage the regenerate, and we need a good quality regenerate. Okay, this is very important and is mandatory in order to succeed. And if we go achieve this kind of result, you can see that the quality of regenerate is good because it's very homogeneous. We have here the black line. What is the black line? The black line is very important because it's the physis of the regenerate, is the area where the regenerate forms, and we can spread it apart in order to achieve lengthening. This black line should stay a few millimeters apart, okay? Meaning that if it's too large, this means regenerate atrophy. We should slow the rate of destruction. If it will be too thin and it will tend to close, of course, we have to speed the destruction up in order to achieve again the line. Otherwise, we will see an example during the case presentation. Otherwise, we will have the fusion of the regenerate, and we won't be able to proceed with the destruction. And at this level, we have these bone microcolumns. Okay, they call them, this is microscopic examination, electronic microscope examination. We call them stalactites and stalagmites, okay? Just in the, like in the cavern, simply because they spread from the proximal and distal part of the osteotomized bone. Okay, and eventually when we reach the desired lengthening, we can stop the destruction procedure and let the regenerate to consolidate. And what is going to happen, that we have this kind of bone columns inside, osteons formation, and eventually once the bone matures, we will get blood cell formation as well. This means that the biologic capabilities of the regenerate is completely the same as the parental bone. And this is a kind of a miracle. I'm involved in this kind of procedure since more than 30 years, and I can guarantee you that every time that I see this kind of image, I think to a miracle. Okay, one of the major features of the regenerate is its vascularization. The vascularization is the main feature because it's hypervascularized. Okay, and this is very important for many reasons. It is soft, meaning that it can bend. And this is the feature that we take advantage of in order to perform many corrections. It can bend following the line of the force that we are applying, and it's hypervascularized. If you see this vascular histogram, you can see that the vessels are many more than in standard bone. And this was the reason why Elizarov was used to say that infection will burn in the fire of regeneration, meaning that if we are able to bring more vascularization to the bone, of course, even in case of infection, we will be able to win the game, because more blood means more biological response. Okay, so now we can start looking to the clinical application of these concepts of destruction osteogenesis. And the first thing that I like is the fact that those are not, as you can see in a second, are not standard cases. So we have to approach them very carefully, meaning that, at least in my experience, almost all the patients that I treat received a suggestion for amputation. In most cases, when I examine the patient and the owner tells me the history of his pet, almost invariably they have this story: they were suggested to amputate the limb for the deformity. And we are just proposing a new option, okay? But since, in my experience, it is not possible to guarantee the final result, we have to be very careful about that, not to make very optimistic perspective, very optimistic promises to the owners. We have to be realistic, okay? We have data, we can talk about data. And of course, we have to select the case because we need to know how to manage it. And we have to be in this very attempt and very critical to ourselves, because we have to be exactly aware of our technical limits. Don't try to make something that you don't have a clue about. Why? Because I guarantee you that we will crash on it, okay? And this will be a nasty experience. So just stay on the side that you feel yourself comfortable. Of course, sometimes you have to take some risk, but the risk should be managed, okay? This is my point. You should know how to manage. And then, of course, we can fail. Yes, this is part of the game. We can fail, but not because we don't know how to manage the problem, okay? Or the complication. And most importantly, select the owner. Why? First of all, because we completely need his or her cooperation. Most of the procedure will be performed at home. And this means, of course, that either can be performed at home or you have to hospitalize the patient, okay? These are the two options. If we talk with the owner, we can realize if they can be good enough or smart enough or experienced enough to manage some of the procedure at home. Secondly, because we don't want to have disappointed owners. So I can't promise them we will have the best result in the world. Your dog will have a new limb. This is not true. So we have to tell the truth to the owner and say, okay, we can try. The result will be partial result, but in my experience can be better than amputation. So we are talking about what is better or what is worse, not is like new, okay? This, I think, it's very important in order to have the compliance by the owner. So in most cases, what I tell to the owner is, please consider that if we will fail with the reconstructive procedure, we should consider again amputation. So it's not something that you can manage like a magic procedure. This is not magic, okay? So please be aware of this. So we start with this golden retriever, male, 5-month-old, with transversal hemimelia. For those who who don't know the definition, hemimelia is when some part of the skeleton is missing, okay? In this case, you will see the pictures of every case in order to realize what we're talking about. So hemimelia, transversal hemimelia, meaning that some part is missing on the transversal plane of the right front limb, and you can see how short it is. The foot is completely missing, even though, and of course it's much shorter, okay? But the good thing about that is that we have the central paw. And this is mandatory. Why? Because if you don't have the central paw, even with a good reconstruction, good lengthening, you will miss the weight-bearing structure. If you don't have the paw to weight bear afterward, it can be a useless procedure. Okay, so please check for that. And of course, we should be aware of the overall clinical and radiographical conditions. So for example, if you can see the comparison between the left and the right humerus and elbow, and as you can easily realize, there are differences, meaning anomalies, even in the overall structure of the humerus. The elbow is not normal. We miss actually the humero-ulnar joint. So we cannot say we will get back to a normal limb, okay? We will try to achieve an honorable compromise. This is the objective, honorable compromise. So this is the left limb and this is the right one. We were missing about 8 centimeters at the time of the first examination, but in very young dogs like this one with open physis, of course, we should consider also the growing part of the story, meaning that in the next 2-3 months, we will get a lengthening, major lengthening of the sound limb. And this means that we should compensate not just for the missing tissue, but also for the one that will be missing because of the growing. And this is quite a challenging situation, okay? So in this case, we can start. This is immediately before the procedure. This is quite straightforward procedure because we just require straight lengthening, meaning we don't need angular corrections. We just need to make this limb long enough to touch the ground, okay? So we can say it's easy, not easy, but easier than the next cases that I'm showing to you. In this case, we need straight lengthening. So I'm using for this kind of procedure always circular fixators. So the frame construct is very simple and straightforward because we just need 2 levels, proximal one, distal one, and in this specific case with just K-wires under tension. Of course, again, I'm not entering in technical details because this would require a 2-day course. We don't have this kind of timing this evening, but let's say that we have this kind of frame. And if you can see here, we can leave this proud part of the threaded bar because we need lengthening, and to lengthen we need bar that is out of the level of the frame in order to use this for lengthening. And in most cases, as this was the case, we need to put even longer bars during the treatment, okay? And then of course we have to perform osteotomy. In this specific case, the osteotomy can be diaphysial. Okay, we don't need to calculate planes of deformity, as is the case, for example, for angular deformity treatment. So superiosteal elevation, and then radial and ulnar osteotomy. And this is the final frame. So this is the procedure, surgical procedure, that means we are preparing the bone for next procedure that will be lengthening. This is PO X-rays. I usually prefer to perform separate surgical approaches for the radial osteotomy and for ulnar osteotomy. It is technically possible to perform the biosseous osteotomy through the same approach, yes, but you have to cut interbone vessels, okay? And I don't like to cut vessels over there, so I would prefer to perform two surgical approaches in order to save the interosseous vessels that we have between radius and ulna, because we need them. After a few days, 3 days usually, in this case at least, of latency to allow the microvasculature to get back, to form back, we can start with lengthening. How? Acting on the nuts of the frame, of course, we can calculate how many nuts facets we have to turn in order to achieve the desired lengthening. So in this case, we start, this is 7 days PO, and this means that we should check if the lengthening, the foreseen lengthening, is confirmed by the X-ray. Why? Because if I don't see the same opening between the two bone stumps that I foresee, of course I have to ask why. Of course I have to check if there is something wrong in our plan, okay? So 19 days, as you can see here, we can start looking to some kind of regenerate, and this is very good. This kind of foggy structure here in the middle, this is the miracle again. And we are opening this regenerate area, and following what are we achieving. This is 31 days recheck. As you can see, the regenerate is good quality one, because we don't have too many holes. It doesn't appear like an atrophic one. Its width is as the same as the bone stump of the osteotomy here. So if it's wide enough, this means good quality regenerate. 53 days post-op. I want the black line to stay open. If I realize that I have the risk that it will be closed, I have to increase the rate of distraction. If I see, like in this case, that is too much wide, I can decide to lower the rate of distraction. This is up to you in order to decide how much you should perform. As you can realize easily in this situation, here the original osteotomy was here and the original osteotomy was here. All this area here in the middle is new bone. Okay, we are creating bone, and this is the miracle itself. Okay, and then at 97 days, I think that it's enough. Okay, in this case, we're able to have a 12 centimeter of new bone So we were able to have 12 centimeter osteogenesis. And as you can see, the bone looks like a good quality bone. We experience a problem, as it is usual in most of those patients. The dog developed a flexure contracture of the elbow. Why flexure contracture can happen in many of these procedures? Because we are lengthening the bone quicker than soft tissues. Soft tissue will lengthen as well eventually, but usually the lengthening of the bone is earlier than lengthening of soft tissues. And in this case, we experience the flexion contracture of the elbow. How can we manage this? By putting two threaded pins over here in the proximal part of the humerus, connecting a long threaded bar to the distal ring here, and acting on this threaded bar to open this angle in order to extend the elbow while we were managing the regeneration of the radius and ulna. Okay, and this was the final result once we removed the frame. Of course, those patients always need a lot of physio. Why? Because they are not used to use the limb. This is the other major issue. If we have a nasty fracture in an old patient, we can be in troubles for getting back the original anatomical structure, but we have a normal reference. In this kind of patients, we don't have a normal reference. Why? Because they were never normal before. So we don't have a normal reference for them, okay? We should find this normal reference for them. And these patients require a lot of physio in order to achieve this kind of joint mobility. So this is another part of the talking with the owners. They should be available to follow for a long time after the lengthening or correcting procedure they pets in order to get back to a physiological or physiological function of the limb. Okay, we have a commercial right now. Stay there. I'll be back in a couple of minutes. As promised, couple of minutes, and then here we are. Now I'd like to start with a new case. It was a little bit more complex, but we will try to share the rationale for this kind of treatment. So we had a right front limb hemimelia with congenital elbow luxation and flexion contracture of the foot. This kind of situation. As you can see, this is completely not functional. And as usual, this dog already had 3-4 suggestions by major orthopedic surgeons here in Italy for amputation. And I think amputation is definitely, let's say, technically correct option, okay? The question is, can we do something better? Let's look together. So this was the X-ray examination and the 3D reconstruction of the elbow. We are not getting into the detailed examination of every kind of deformity. It will take the whole hour alone, but please be aware of this elbow luxation. When we have this kind of, and this was the clinical situation of the dog, not functional. The dog was very, very nice dog, and this was the reason why I fall in love with this breed at that time. And the first thing is, when we have elbow luxation, congenital elbow luxation, I don't like and I don't agree to perform radial head osteotomy. I follow a different approach, and my approach is to lengthen the ulna in order to achieve room enough to accommodate for the radius. Okay, so this is the distractor. The procedure is very simple. So this is the approach, surgical approach to the ulna. This is the distractor with a threaded bar. We can start like this. We have the radial head, this out of the elbow joint, and we don't have the option to put it underneath the humerus because we don't have room enough to do that. So we are just lengthening the ulna. And this is very simple, very straightforward, but eventually we will have room enough to get back to this joint contact. Will it be a normal elbow? Not at all, okay? Not at all. Don't think that it can be a normal elbow or normal looking elbow. What we are looking for is a functional, more or less functional elbow, okay? But this is the procedure. Don't cut the radius, please. And this was the situation during the treatment. It is very well tolerated. Look to how nice was the dog. But we still had the problem of flexion contracture of the foot. We evaluated at that time many options, okay? Arthrodesis, cutting of the flexor tendons, whatever, but I decided to go another way. Perhaps a little more complicated, but I wanted to preserve as much as possible because we had the problem also of, we had just two fingers. Okay, so we had to decide exactly how to put those fingers in order to allow for weight bearing. And okay, as you can realize, is not the kind of frame or treatment to start with the first time in your professional career. This is something that, of course, we should evaluate, but at a next step, after having a little bit of experience with simpler cases, okay, we were trying to get simultaneously the correction of the flexural contracture of the carpus and reducing the radial head in its physiological positioning. And we had to make many changes during the treatment because, for example, the major problem is that changing this position by means of the motor bar that will act on these hinges, and the hinges will make the work, okay? But we experienced, for example, some contact between the frame and the limb. And at that moment, we should change the frame in order not to bother the limb, not to damage the limb. The good thing about that is that in most cases, you can make this change with the awake patient. You don't need to perform general anesthesia or to put the patient under general anesthesia every time. Most of these changes can be done with the awake patient. Why? Because if you are working on the frame itself is not painful for the patient, okay? This is very straightforward, okay? So we are trying to change this and in this case, the owner was not able to manage all the corrections that were requested during the treatment. And this was the reason why the dog was hospitalized for 8 months, okay? 8 months. And this is why I told you before, be prepared to manage situations, okay? But, okay, if this is the way to succeed, I'm available for that. Until we proceeded, until we can achieve complete straightening of the limb. And the goodness of the frames, external frames of this kind, is that the frame can be easily changed according to the need. So in this case, we eventually succeeded for the proximal part of the frame, and we had just to decide how to put those fingers, the only 2 fingers that we had, in the correct positioning to achieve weight bearing, okay? And this was more or less the final situation. This is when we removed the frame. I was not very happy that day because the posture of the limb was not exactly as expected, but of course, this is what we got at that time. And this is how was the radiographical appearance. So this is more or less an elbow, and this is more or less a straight limb, okay, more or less. Honorable compromise, okay? But, as you know, biology is the best surgeon in the world, much better than all us, okay? So, this was after 1 month. And after 1 month, this was already weight bearing and with flexion on the elbow, and more interestingly in flexion of the carpus as well. So we were convinced that we were on the right path, and it was convinced by this movie that the owner sent me 1 year after the procedure. This, of course, this one is the operated leg, and as you can see, we can say that it's not perfect, of course, but it's very functional. So I say, okay, this is the kind of result that I was waiting for. Okay, this is the kind of result that we can foresee, meaning that I'm convinced that with this kind of result, we can have the feeling that we were helpful for the patient. Okay, This is the major point. Just a couple of commercial more, and I'll be back soon. Okay, thank you. Okay, here again, for the last case that I'm sharing with you, one of the most complex situations that we may be called to front, because in this case we have left front hemimelia with congenital luxation of the elbow, but in a way that is not very standard way, if a standard exists. Usually the owner realizes that there is something wrong since the very, very early stage of the puppy life, okay? This is the first picture that the owner sent me asking, what is this? And I didn't realize from those pictures that the owner is came from abroad. So she was not able to come very early, but we managed through the referring vet. And I wasn't able to understand exactly what was going on by these pictures, but when they sent me the X-rays, this is the normal right limb. As you can see, the structure of the puppy elbow here and the puppy carpus here, normal structure, okay? If you look to this, we have different situation. And what was very astonishing to me was not just the fact that we have elbow luxation, but the fact that the carpus was not shared between the ulna and the radius, because the radius was bearing just the first digit and the ulna was bearing the rest of the carpus with all the metacarpi. Okay, so this is kind of tricky situation. I had the opportunity to examine the dog when he was 5 months old, and this was the clinical appearance. So we have the foot that was not only varus, sinus, instead it was 180 degrees rotated upward, like that. Okay, so this is the radius with the first digit alone, and this was the ulna here with all the carpus at the foot. The major problem was that if you look to this, I will show in a second what is the relationship between the radius and the ulna. So this was the clinical situation of the dog with this foot, very strange position, but he was using more or less the limb, of course, putting all the weight bearing on the dorsal surface of the carpus. That is not good because it will ulcerate eventually. Examining the situation of the foot, I could easily realize that radius and ulna were not connected at all. And this makes a huge difference in the treatment, huge difference. Because if you saw the case of the terrier before, of course, we can say that distracting the ulna, we can create the room for putting the radial head into its positioning underneath the humerus. But this is true provided they are connected here. If they are not connected, you can distract the ulna, but you are not pulling on the radius. So this requires a specific procedure, okay? And this is the, okay, just for your better comprehension, this is a 3D reconstruction. You can see the overall condition. Please note this, that the foot is not just rotated upward, but also is rotated on the long axis. If you extend this foot, look, if you extend this foot, you can easily realize that the dorsal part of the foot will be directed caudally, not cranially. So it's rotated in two directions, in two different planes that are exactly the opposite they should be. Okay, so this is the challenging feature of this case. Of course, when we have to, where you front this kind of situation, if the talk with the owner should be a thorough talk, this should be even more thorough, even more detailed, even more cautious. I mean, this owner should understand that we are not willing with something that is completely predictable, okay? There is something unpredictable left in this kind of situation. So we decided to divide the procedure in two parts. First part, extend and position correctly the foot. Second part, put the radius in its physiological, more or less physiological position into the elbow joint, okay? So this is the frame to start with for lengthening. This is the easier part of the story, like the first one, the golden retriever, with the difference that this is an angular correction. So we are acting on this motor bar here, but we have the hinges here. So acting on the motor bar, the hinges, if correctly positioned, of course, this is the difficult part of the story. You should calculate exactly where the rotation, the center of rotation is. And we can act on the motor bar to achieve extension of the foot of the carpus. We start like this at time 0. And after 7 days, you see that this angle is opening. even more, 14 days, and after 21 days, 3 weeks, we are in the correct alignment. Please note this. We are here hyper-correcting. Why? Because with just a calculated procedure, it was not enough. And this is one of the major advantages that I see using circular fixators for correcting deformities instead of plate internal osteosynthesis. Why? Because with internal osteosynthesis, you have to decide into the OR what you are doing with that deformity. If you are wrong, you will stay wrong. You don't have the option once you put the plate, apart that in this age of the dog is not possible to do that. But let's say that generally speaking, once you put the plate, you will stay with that plate, with that alignment. With a circular fixator, progressive distraction, progressive correction, you can change the plan. You can set the fixator according to the changes. And this is the big tool, that they are, okay? Once I have the foot straight, I have to lengthen the ulna to create room. But as we told before, radius and ulna are not connected. And this is the reason why we should prepare a new frame, adding this part with a specific drop K-wire. Drop means outside of the plane of the ring, this one, in order to distract this part, performing, as you can see here, osteotomy of the ulna. So we can make the correction of the ulna by lengthening the ulna, and in the same time, thanks to this drop wire, to pull on the radius in order to get this reduction. As you can easily realize, this is a nasty situation, okay? Nasty situation to start with. After 42 days, we realized that we have this regenerate healing. We were too slow. And this was the reason why at 48 days from the first surgery, we are talking from the beginning, time 0, okay, not after the osteotomy, we had the regenerate that was completely healed. We can't progress like this, okay? So at 48 days, we decided to repeat the osteotomy. Is the procedure very complex? No, it's not very complex. It's very easy, very straightforward, but we require a new procedure, a new surgical approach, new osteotomy, okay, new something. This is the difficult part of the story. And then we can start again. But of course, in this way, much higher rate. At this point, we arrived up to 3 millimeter every day of distraction. 3 millimeter, this is a huge amount, okay? And of course, we tried to bring back the radial head to what it was supposed, its original position. 59 days, we don't get the final result we wanted. 69 days, we are more or less in the situation that we see that the regenerate is almost fused, and at 70 days, we eventually, finally get the radial head underneath the humerus. It was like, okay, it was like that. But what is the price that we paid? Look to the ulna, to the semilunar notch of the ulna. It's outside of the contact with the humeral condyle. So we decided to stabilize it in a different way. We got back to the OR and we decided to pull the radial head by means of these olive wires. What is an olive wire? These are not actually olive wire, because olive means a ball, okay? A ball that doesn't pass through the bone, and if you pull on the wire, the ball will push the bone. I don't use olive wires, but I use these bent wires. The fact is the same. If I bend the wire and I pull on it, I can pull the bone, okay? And the objective, the aim of the procedure was to hold the radial head underneath the humerus. But if you see more closely to the procedure, you can see that I pulled too much and I fractured here distally to the radial head. So it was at that time, it was a couple of days before Christmas. And I said, okay, we cannot move it anymore because we are breaking the bone. So we decided to send the dog home for Christmas and to get back to him the few days in January, the first days of the new year. And after a while, we got back to him and we saw this. I was not very happy because when we removed, of course, the fracture was healed, but when we removed the frame, this was the situation, better than before, but it was not an elbow, because when I flexed the elbow, this radial head was escaping cranially. I was not able to put it underneath the humerus. So I decided to operate the elbow. And I realized why we were not able to put the radial head again back in its position. And the reason was that we had a joint capsule that was including just the humerus and the ulna, but not the radius. The radius was outside the joint capsule. So I have to incise, I have to cut the joint capsule, open it, bring the radial head inside it, and stabilize the radial head again. And as you can see here, I decided to stabilize the radius and the carpus together with a very elastic joint, very simple one, Kirchner wire with the extremities, band extremities, okay? With the band extremities, very simple, very straightforward. Why? Because I didn't know, I couldn't foresee at that time what could have happened later on, okay? So I decided to stay in an open situation. And this is the dog after 1 month from the procedure. So of course the limb is not normal, but he was using the limb for playing, and this was quite funny to see that he was playing, where using the the limb to move the stone. And we found that a very nice exercise for physio in this dog was digging holes, okay? So the owner lives in the countryside, so no problem in digging holes for the dog. This wouldn't be good in my garden, okay? But in open country, it's good enough. Of course, apart jokes, the owner, I think she was one of the best and most dedicated owner that I ever knew in my career, because she was performing everyday physio and educational training for the dog in order to stimulate the proprioception of the limb of the dog. And every day is every day, okay? And this is a quite tough and demanding situation. But I think that at the end we were able to recover, at least partially, of course, honorable compromise. This is the objective. It's not new limb, okay? Honorable compromise. And I think that this is what I had to share with you. If you have questions of the next day, you can write to me, but I'm going to tell you again after the question and after the commercial. I'll be back in a couple of minutes. Thank you.